Hey, Fix listeners. I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So, if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy.
And you're listening to the Fix Podcast. Hello, and welcome back to the Fix Podcast. We are here with a pioneer in implant dentistry, Dr. Logan Locke. We are super fortunate that he's been willing to spare his time with us, and we're going to be covering some really interesting concepts, a little bit different from the typical fare that Soren and I talk about. So I think in this episode, he and I are probably going to be taking a little bit of a back seat and learning about some interesting surgical and prosthetic concepts and different ways of thinking about and approaching full arch. So, Dr. Logan, we really appreciate you coming on.
Yeah, happy to be here. Thanks for having me on, guys.
Awesome. So for those who are not aware of you, those shamed people may they be, could you help us out just a little bit and kind of give us a little bit of a story of how you got to where you're at and where you're at?
Yeah, so name's Logan Locke. I'm on here basically because I've been with 3 on 6 for basically since its beginning. My partner Randy Roberts and myself. He really started it back in like 2016, and I jumped on shortly after that. We started doing the first cases in our office, and I assume we'll get into 3 on 6. I myself born and raised in Utah, went to Creighton for dental school, and just kind of gained a passion for implant dentistry there. Had some really awesome mentors. Can't say enough about how much they allowed me to do in dental school, which I think after talking to a lot of people, I thought it was normal. But I think my experience in school was far different than most. And then, so came to work for Dr. Randy Roberts, and we just did a billion low-cost implants, and that's kind of how we got started with into full arch as it slowly progressed, and into attempting FP1 basically.
Okay, and so what was kind of just the general landscape back in that time? So you said a billion low-cost implants. What did that look like? What were most people in your town doing at the time? What was the market?
Yeah, so Utah is a heavily saturated place. It is hard to compete in this area. And so we were running basically a quantity program. We were doing implant, abutment, crown all the way through for $1,500. We were using, when I first started, we were using high-tech implants. I think I don't even know where they're out of. And then we slowly transitioned to Neodent CM. We were doing most of our crowns on a CEREC. So, we did a lot of implants, and it really, experience-wise, I couldn't have asked for more. But it had its own challenges, and so yeah, that's $1,500 all the way through. I wouldn't do that right now, but it definitely got me some good experience.
For sure. That's awesome. And so, being sort of the economy, I guess, single implant guy, were you approaching full arch at the time, or was there a modality that you guys were utilizing at the time for that, or was it more just like single tooth replacement, bridges and things like
Mostly that? Single tooth and implant bridge, and then I started to dive into All on X. So I took some courses on that, did quite a few cases. That's about around 2017 is when my partner Randy started doing. He essentially started doing FP1 with CEREC Blue Cam, and he had a cousin that needed a full mouth. He didn't want to remove bone. Decided to put some implants in, and after they healed up, we put just stock abutments on and scanned them, and then we designed our own bridges. They did not look the most beautiful at that time, but it functioned, and that's kind of how the whole thing began.
Okay, so yeah, I'm very naive to the concept of 3-on-6. I mean, I've looked at it, I kind of know it from just a bird's eye view, but the basics of that I know is that you were working, it's a FP1 full arch method where you have segmented arches. So it's a total of 6 implants and 3 separate restorations that are just kind of butted up once against one another in a way that looks, fluid and looks like a full arch. But that's about as far as I go. So I'm interested to see what kind of advantages you guys saw versus All-in-X. And I love that you have that All-in-X background. So what was so attractive about that modality?
The gist of it was, we started to see, once we did the first cases, we got people coming in and they're like, we really like this. And it was super, super challenging at the time to do even a full arch bridge. We'd try one piece, but our pucks weren't big enough. The cost to go through a lab was incredible. It was just way too high to try and have these fabricated at the labs that we were using. They were weaker when they were one piece, so we'd see fracture more frequently. We were using Emax at the time because it's just what we could mill out. So 3-on-6 basically is a FP1 modality. By no means did we invent FP1, obviously. Right. But the main issues that we saw, we had a younger patient base coming in, a lot of addiction, completely broken down dentition, and they needed full arch. And the problem that we saw, or the ethical dilemma I think that we felt, was the bone removal. We know this stuff isn't going to last forever. And so when we were looking at, 7 to 15 sometimes millimeters of bone reduction in order to hide a lip line or create a prosthetic space in a 28-year-old, it just we decided we wanted to look at other options. So 3-on-6 is an FP1 modality. It's a way from start to finish to do FP1/FP2 consistently and affordably. So we essentially found that we couldn't use outside labs because they weren't proficient enough to get the Pontic site development that we required. They were way too expensive, so we were having to charge patients way too high of fees, and so they just didn't want to do it. So our barriers were bring the cost of the procedure down, bring the skill needed down because it is a tougher procedure to do, and make it so that more people could do it consistently. And that's kind of where, and I guess the latter part of it is create something that's marketable, because no one knows what FP1 is. Patients don't understand. And often I think patients don't understand when they're getting an All-in-X. They don't understand that they're going to have fake gum tissue, that they're going to have bone removal, because often we just don't, that's part of the process. We don't describe that when we're selling a patient, which I don't think is, it's just part of the process. But most of the people that come to see us didn't know that until they Googled it after a consult.
Okay. So one thing you said there, I can kind of imagine some people having a little bit of a knee-jerk reaction too, if they're kind of very set in the, All-in-X cross arch stability world, as you said that it was weaker when you were doing one piece all the way across the arch. So how did segmenting help us out with that? Yeah.
So the reason we need a prosthetic space, right, is for the strength of the prosthetic. And so that's part of the reason that we have to remove bone. Cross arch stability is crucial for the initial stability and the healing of the implants. And our initial prosthetic is one piece. We want cross arch stability. We want those implants to be supported during the healing time. And then after that is, once the implants have integrated, that's when we start to segment in order to give them, one, a more durable prosthetic, and two, we want to start increasing the load on the implants. We looked at a lot of research for, when we look at, say, an all on 6, let's say we're doing 6 implants, The research that we found suggests that the anterior 2 implants get the bulk of the load, the posterior 2 implants get the bulk of the load, and really the ones in the middle aren't taking much. They're not providing a ton of extra support. And we know that implants don't do well when there's not a load against them. We've all seen an implant come in with a healing abutment after 10 years that never got restored. You're always bone loss. And so the idea of
it's progressive loading, I guess.
Progressive loading these implants as they heal is kind of what drove us. Well, honestly, the initial part was as big of a puck as we had, or as big of a block as we could mill with our CEREC. That's as big as we could get. But then we started, looking into it further, and it was working, and implants were retaining bone, and we were getting really good scans of bone density and bone deposition, and so we basically, it was a accident. Well, not an accident, but kind of lucked into something that we believe works better long term and distributes load more evenly across more implants.
That makes sense.
So a question that I have for you as far as the 3-on-6 goes is, that makes sense to me. I think the first thing I thought of when looking at 3-on-6, I think the first argument a lot of people have regarding it that I've seen is there's no cross arch stability for, to get past that primary stability portion of the implant. And if you are getting that cross arch stability, that's great. A question I have though is, let's say when we're doing a fixed prosthetic on 4 or 6 implants, and what our philosophy is, we typically do pterygoids in every case.
Okay.
So we're doing all on 6 with 4 on the anterior. And where we see a big benefit to that is if an implant fails down the line, right? There's a lot of real estate where we can remove an implant, place another one, and load another temp, or even if they are at the phase of zirconia, mill another zirconia pretty easily. How do you guys combat the issue of, if you have 3 different bridges and one implant fails? I feel like that might be a bigger headache for you as the clinician to then go in there, and you might be kind of limited with the amount of space and bone that you have to replace that single implant on those bridges.
For sure. Yeah. So, if we're talking, 10 years, they're already in segmented bridges, they come back and an implant's failed. It's pretty easy for us to be able to take our design and basically remove one of those splits. So, maybe we turn it into a 2-on-5, basically creating those segments in different areas. Worst case scenario, we can turn it into a full arch prosthetic, and at that point, your biggest weakness is just the full arch. One big piece of zirconia, it tends to fracture more frequently. So at that point, we'd maybe warn the patient that that's something that could happen down the road. Being that we're not having a 12 millimeter restorative space, so oftentimes we're in the 6 to 8 millimeters. So that's kind of the worst case scenario, but we find that it leaves us so many more opportunities, because we've got these implants in, but we didn't remove any bone. We kept every ounce of bone that they had at the beginning. We're placing these implants at a prosthetic spot where we're getting good pontic site development. And then let's say 30 years from now, this sucker fails, we're getting bone loss, and it just doesn't look good anymore. We'll take the implants out, we'll put them in an all-on-X, and we'll do some pterygoids. We do. A lot of our providers are placing pterygoids. They're using those within a 3-on-6/4-on-8 framework where we're still segmenting against those pterygoids. So all of the things can still be applied. My belief is that we're giving them an extended life on what bone they have, because it's, all of this stuff, how long it lasts, we're going to see the ramifications of what we're doing. I think 30 years from now, we'll see what happens with all these full arch cases. But if we've got a lot of bone and we can still go to an all-on-X from a 3-on-6, then great.
Okay, so in other words, if you're losing one of your guys down the road, this is a long-term failure, like late failure.
Yeah.
5-10 years down the road, you could lose that implant, and you don't necessarily need to be replacing that implant and just making a new segment. You're actually now going to refabricate a whole new one that connects two segments, so that way, it's kind of like you didn't really lose much at all because the other implants were already integrated. So now you're just sort of swapping it out, going from 3-on-6 to 2-on-5, or maybe you started 4-on-8. I had to think about that one.
Yeah, you got to think about how many bridges are on now. No, yeah, and if you think about it, I mean, so our general placement of implants, if we can get them straight up and down in the first molar area, great. But we still angle with the sinus quite a bit in the posterior. So let's say 3 to 4 to we almost always place an implant in at number 6 at our canine sites. So 6 and 11 are getting implants, and then 7 and 10 generally. Now, if we had number 7 fail, I'll just put an implant. We grafted everything. We graft every single socket that we take out of. So usually I have let's say 7 fails. I'm going to put an implant in at 8. I'll cantilever 7 off of it, and I've still got a 3-on-6. So there's still a lot of opportunity to move things around with what we're doing, because we generally keep just a ton of bone.
And I really too like.
Yeah, I really like that. Yeah, I was just gonna say I really like the idea of it, because something that we talk a lot about on the podcast is the fact that and that primarily what we are doing is FP3, and what ends up happening is, right, you have patients that go into FP3. That being said, a lot of our patients are patients that come in that that have an indenture, or they've been missing their posterior teeth for a really long time, so it's not like a huge jump to go to FP3. But it sounds like a lot of your patients you guys are marketing towards, so maybe you're seeing some younger patients with addiction issues or whatever it may be that's causing that decay earlier on in their life. But something we definitely talk about is the fact that when we remove that initial bone and we go to the FP3 style, down the line, if something fails, then you're getting into some of the more advanced implant techniques like zygomatic
remote anchorage
implants.
stuff.
Yeah, definitely. Yeah. Even we're kind of seeing subs now and all this other stuff to repair those defects that they initially had. So it's kind of like your initial set of teeth is phase 1, FP3 would be phase 2, and then a remote anchorage is phase 3. But you guys are just adding another phase on it, which is wonderful for the potential of the lifespan of these implants.
Yeah.
How do you see like the tissue over time? Are you losing any of those papillas over time? Are you having any issues with aesthetic concerns? That's something that has even like FP1 has kind of made me nervous about going into and doing a lot of FP1 cases, is because if that, what FP3 allows us to do is it kind of avoids any of the aesthetic recession problems.
Yeah.
So I'm curious what you have been seeing over time and how you combat those problems, if you do see them.
So the way that we do the case, and the way that we train guys to create really as much keratinized tissue as possible, we're finding more and more that's what drives the success of the implant. So when we're doing an FP1, we're using the initial prosthetic, the temps, to separate the keratinized tissue. Let's say on the upper, we're going to pull a lot of tissue from the palate the day of surgery, and we're going to leave it. We're going to leave the bone basically exposed under the prosthetic, and we're going to allow secondary intention to fill in that area. And so we tend to get really, really good KG over time. Do we still see a little bit of gold from an abutment showing from an MUA? Yeah, we can get some of that stuff over time. We're not seeing most of my patients' papillas remains awesome, assuming that they're cleaning it. Papillas remains good. Everything's hidden underneath the tissue, but occasionally we have a little MUA exposed. That's about the extent of the issues that we're seeing. And that's, for me, that's a sacrifice I'm willing to explain to the patient, why they have a little gold exposed when they pull their lip up real high.
Yeah. Is there anything you do about that? Like if it's in an aesthetic zone?
We'll try. If they're showing it when they're smiling, then we'll get some alloderm in there. We'll try and cover it up. We'll generally we try and plan our cases with with space to drop down MUAs. So we plant our implants fairly deep, use a longer MUA to start, try and gain the tissue at that. And then if we need to drop it down later on, we can and hide that MUA.
Got it.
Yeah.
Are you able to I know that, I mean, if anything you feel uncomfortable sharing, like just let us know. We're happy to keep it. I was just curious what the prosthetic the surgical workflow looks for you guys. You said that you leave some bone under the prosthetic, which makes sense. But like, are you guys, is it 2 millimeters that you kind of like give between the prosthetic and the crest of the bone in order for that tissue to heal in, or what does that kind of look like? And then are basically you suturing under, because that's like kind of typical FP1 style, right?
Yeah.
So I'm just curious kind of what that surgical workflow looks for you guys. And yeah.
Yeah. So gist of it, once we have our implants in, for the most part, we're photogrammetry and printing same day. Our lab for all of our providers is basically they get scheduled for the day of surgery so they can immediately convert the wax up, and we can print it and just go direct to connection. We place the prosthetic, and oftentimes we are going to allow the prosthetic to drive any resorption that may happen. So a lot of times we see uneven bone. It's pretty rare for us to remove bone, usually only a really gummy smile, but we'll seat the prosthetic up touching the bone. We usually try and keep it 1.5 millimeters to 2 millimeters off of the bone, but we'll let those pontics, in the posterior, oftentimes where it's uneven, or we're switching from 2 premolars and 2 molars to 1 premolar and 2 molars, that prosthetic is going to drive the resorption. And then as the KG fills in underneath it, it's going to create that pontic shape and size that we want and that thick keratinized tissue.
Got it. Are you guys flapping during your procedures, or typically, like, I'm just curious about the surgical workflow.
Yeah.
So is it extraction, no flap, implants kind of go where you can find that initial bone, and then you just go to because if it's that way, it seems like it'd be a pretty efficient surgery.
Yeah. A lot of the time we can do it flapless, depending on what sort of dentition they're currently in. This is a fully guided surgery for the most part. So we almost always require our licensees so that we can manage the implant placement. We help them plan the cases, get the guide sent over. So everything for the most part is guided into place, because it's such a difficult procedure to get those MUAs and those screw access channels coming out, not out of an embrasure. So everything's pre-planned. But yes, oftentimes we'll flap, like I said, on the upper. A lot of times, if I'm missing posterior teeth, I'm going to pull a lot of that KG from the palate. I'm going to move it over to the buckle of my prosthetic and leave the bone exposed underneath and let that fill in. If they've got a full set of dentition, then we can do the cases without flapping. And basically our lab is just going to get every pontic right into the sites where the teeth were originally. So, we like to say if we're treating these cases exactly as if you had a patient lose 7 through 10. And, at that point, we're not removing bone. We're not trying to hide a prosthetic really high. We're going to try and create as natural of a papilla and natural of an appearance as we possibly can with a bridge from 7 to 10. We're doing the same thing, just all the way across.
Got it. That definitely makes sense.
And it sounds like everything is going to have an MUA. You're not going direct to fixture; it's going to the MUA, or do you do some direct to fixture? I'm just kind of curious about some of the prosthetic nuances of it.
Yeah, we've tried a few different systems. So we started off doing all of these cement retained. The first cases that we did in the first 3 or 4 years, probably, we were doing fully cement retained cases. They turned out really beautiful. Still some of my best cases as far as pontic site and tissue development came from those cement retained cases, but it was really complicated and really it threw off a lot of providers that just didn't want to deal with how complicated it got.
Yeah.
Now everything we do is basically direct connection on MUAs, all screw retained. We have tried a couple implant systems out that would go direct to implant with immediately printing and putting that connection really close to the bone. It worries me a little bit. So I prefer to have a little bit of space with an MUA, but we can, that's the other part of, if you have, an MUA exposed, we can always put on, either custom or stock abutments for that specific bridge. And you could pivot that way as well to drop that closer to the implant level.
It does seem to me that kind of the keystone in being able to do this and be flexible with any type of prosthetic complications that either happen now or later is that you're able to make these with your own lab. I can imagine if you're very dependent on sending out to external labs and you're paying a large lab bill for this and you start having some complications and having to change the schema of this whole 3-on-6 thing, it can very quickly land you being underwater. Would that be
I mean, that was the initial issue that we had, is they're charging us, however many dollars per unit, and we're making this huge bridge. So, you have to replace even an immediately printed case where they didn't want to send you the file, or you had to pay extra to get the file so you could keep printing it in case you had any issues. It just it was too much. I mean, I remember taking my first All-in-X courses, and they would brush over FP1. They told us about the different classifications, and they would say, FP1, this is the unicorn. It's for only very specific patients. It's really complicated, and you have to charge your patients $80,000 per arch. And it was like, man, I'll probably never do that. We created our lab in order to essentially remove that for ourselves, and then it turned into removing that for our licensees. So, for us, let's say we had to remill a full arch, I think our lab right now is charging maybe $300 for the full arch of zirconia in a remill. It might be less than that, I'm not sure. But as far as our pricing goes, just to kind of give a framework of things, we deliver basically the full arch to our licensees for $5,000 an arch. That includes the implants, the abutments, the immediate prosthetic, the secondary prosthetic, the final zirconia. So basically your surgery in a box is $5,000, and that's a surgical guide as well. So we feel like it's a pretty fair price for everything you get, especially when it's including the implants and abutments. And then, like I said, we take those costs, and any redos, remakes, anything like that, we just lower it as much as we can so that people aren't restricted by the cost of things.
Wow. So are all the people that you guys are licensing out to, I assume this means they can market 3-on-6 and say that they're 3-on-6 providers. They're all going through the lab that you guys developed, and then that's a hub and spoke type of thing. Yeah.
So that's the only thing we require. We kind of have, over the years, it's kind of created these fan clubs, which is kind of funny. We get these groups on Facebook that just love their 3-on-6. And so we get all these patients coming into these groups. And one of the issues that we found early on is patients being afraid that they're going to get a worse or a different product than if they came to Utah to see us. And that's one of the hurdles that we wanted to get past, because even still, most of our patients fly in from out of state searching for this. So as we started to put these providers out, we wanted them to be delivering the exact same stuff that we were putting out, so that we could go on there and say, no, don't come to Utah.
That's your name.
Stay there. Yeah. You're getting the same exact product. So we do require, if you're marketing 3-on-6, use our lab, use the implants, so that we can say essentially, go stay in Chicago. We've got a great doctor there. He's doing the exact same stuff.
Okay. So what is kind of that sort of curriculum? So let's say somebody wants to incorporate doing 3-on-6 and they reach out to you guys and now they want to get into that world. A, what do they have to do to get involved in it? And B, once you see that person that wants to do it, what do you need to see from them in order for you to say, okay, you're good to do this?
Yeah. So We hold a training out here in Salt Lake. It's essentially a 4-day training, Wednesday through Saturday. Wednesday's didactic, Thursday basically full model work, Friday some prep for a surgery, and then Saturday where we get each trainee an arch of 3-on-6 to do on just some of our own patients that couldn't afford it full price. So everyone gets to do a full arch when they come through our training. The cost of the training is $25,000. It include $5,000 of that is our one-time licensing fee. So we don't charge any licensing fees beyond that. That gets you kind of up on our website as a provider. From there, if we feel like a student needs a little bit more one-on-one time before we can confidently put them up on our website, then we suggest kind of some further training, which we can do. I've traveled out to a lot of our licensees' offices that kind of want to run it in their own office, and I'll help them get their staff set up and help them run through the workflow, get their printers all going, just make sure everything's dialed in their own space, so they feel confident doing it.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
And what would you say is kind of like a baseline, I have X amount of skill, I'm ready to go do this 4-day course, and by the end of it, I'm going to be, probably ready to go and do some 3-on-6?
Yeah, we require them to have placed, I think, at least 150 implants is where we, just kind of guessed where we wanted them to be. We love getting FP3 providers because they're just so much more used to surgical complications. So we have guys that have come through that are just amazing FP3 providers that just added this to their workflow. They charge more for it because it's more complicated and a longer surgery.
Sure.
And they're still doing, they can place pterygoids super easy. They can do everything. And it makes our lives a lot easier when these guys come through and they have all that experience. But we've also trained doctors, general dentists that looked at FP3, said they didn't feel great about some of the issues with FP3. And so this is their entry into full arch. And it just requires a little bit more input on our end. And we feel like we've kind of created a family within this 3-on-6 group where these providers, they'll text me directly. We walk them through cases. I'll jump on and help with their implant planning. For their first 4 arches after they've gone through the training, I basically manage all of their cases start to finish to make sure that the wax ups are done properly, that we go through their implant planning together to make sure that they're thinking of different things that can arise during surgery. We try and really baby them into this because it is complicated. And most of them have just taken it and ran with it. So it's been great to see.
So is that to say that, after they've had those first sort of, cases where you've been holding hands through the planning and everything, they're feeling confident to go ahead and do their own implant planning and their own surgical guide fabrication? Mm-hmm. Like at what point are they having to coordinate with your lab? Is that just when the final prosthetics come along for the second?
No, so they're doing it from the beginning. So our lab will does the wax up. We have one employee that does all the implant planning because she knows how we like them planned. And so she's going to guide all of the surgeons, all of our our licensees through the implant planning process. I'm on a Teams chat for every single one of those. So if any of them have a question, they kind of just tag me in those things, and I can hop in and help them with the implant planning if it seems like a more complicated case. We try and make it so we're as available as possible to help them through those. But yeah, after 4 arches, I guess their initial arch during training, we baby them through their first 4, and then we kind of set them loose, and they just ask us if they need anything from there.
Wow. So am I to assume, and correct me if I'm wrong, because you have mentioned using pterygoids and things like that. So in my head, when I'm thinking about doing, 6 implants and, when I've seen most FP1 cases, like this is usually going to be a younger patient, not necessarily, but they've got, bone in all the Bedrosian zones. Like you've got bone that you can use all the way back to the posterior, and we're probably placing axial implants, but in some situations we're tilting a little bit. Like how do these usually end up looking? Do we have angle implants?
Yeah,
axial,
we usually, I would say most cases we have to angle with the sinus still. These type of patients at this point, they've lost at least some bone in the posterior.
Sure.
So we do angle it. I would say what we find is a lot of patients that you maybe wouldn't think are candidates for FP1 are in fact candidates, or maybe verge into an FP2 type of territory. But the comments that we get more frequently than not are, I don't want fake gum tissue, and I don't want any of my bone removed. Those are the 2 main things people come to see us for. And so if the teeth end up a little bit longer than a natural tooth, then it's generally not a concern for most patients. Now, some are going to be pretty picky about it. And then if it feels like they're going to be very picky, then we go through the FP3 process as well, discuss how we can make their tissue maybe look a little bit better if they go through that. But here are the drawbacks. We have to remove a little bit of bone. We have to hide that joint up a little higher. So as long as we're providing that context to patients, then I think we're in good shape. But yeah, as far as the implants, the planning goes, I think you'd be surprised how many patients are candidates for this. And basic framework, if we can get implants straight up and down in the posterior, we're going to do it. If we can't, we'll move to pterygoids, we'll angle with the sinus. But we almost always have to get implants in at 6 and 11. And then we will do 7 and 10 is kind of our primary place for, so laterals. But we will oftentimes, if lateral bone isn't great, we'll place at 8 and 9, cantilever off laterals. But almost never cantilever a canine on the upper.
Okay.
So I guess that leads to one of the trickiest parts of this whole thing is just learning how to do atraumatic extractions, because I think that's where we see the most issues with our licensees is they come in and that canine buccal plate's gone. And then it presents a ton of issues moving forward. So we really harp on atraumatic extractions, getting the teeth out without destroying the buccal plate. We have some doctors that socket shield, that do some of these other techniques to help keep that bone in place. So there's a lot of stuff we can do to help keep that bone in place.
Do you have any tips for people on atraumatic extractions and kind of things that you like to do to try to prevent and restore that buccal plate?
Yeah, so the main thing that I use an ash forceps for almost every anterior extraction.
Yeah.
If you can figure out rotational movement and shoving it up into their brain as you're rotating, you can generally get the canines out without removing any bone. You can get most teeth out without removing any bone. I section canines all the time. I will break it into 1,000 pieces before I'll let the buccal plate go. So that's one of the things we focus on a lot is, okay, this is how you're going to section it. In order to preserve the buccal plate, we'll use our guide, and we'll just, if there's a root tip left, we'll drill straight through it, use that space to pull the rest of the tooth out. There's a lot of lot of techniques that we go throughout our course that kind of help guide them on how to prevent bone loss.
Yeah. Yeah. I mean, I think that's one thing that initially, as you're kind of walking us through the surgical approach here, that's what pings off in my head is, when you have this, full dentition, you need atraumatic extraction. You probably got a bunch of teeth that are broken off below the gum line, trying to be conservative with your flap, trying to work with the surgical guy, trying to make sure things come out in one place. Like that's not an easy thing to do. And
No.
if you're primarily an FP3 provider, you don't worry quite as much about those things. And frankly, even if you break off a buccal plate, you'll probably still be okay.
You move around
a
it.
lot of
Yeah.
times. Yeah, you don't really need that type of architecture. So this is definitely a much more intricate and delicate procedure, at least as it appears to me.
Yeah, and it will take you longer. We have a lot of guys that come out, and I think I've talked to a few that say, well, I've done a ton of FP3. I don't need the training. Can I just get going? And it's like, no, we got to have you come out. We got to go through this stuff because it is more complicated than you would think. And the surgeries tend to take 7-8 hours, whereas you can do a full mouth FP3 a lot quicker than that. Most FP3 providers can. So the cases, they're longer. It takes more time to do this, and so that's why we generally tell our providers, charge more for it. When a patient comes in, if you want to sell them on an FE1, you got to sell them on what it is and the difficulty of it, and this is why it costs a little bit more than the FP3. Make it worth your time, because it's a longer procedure, and you're going to be in there for a bit more time.
Yeah. Yeah.
What do you typically charge for, if you don't mind, for like your all or 3-on-6 procedure?
In Utah, we're about 25 an arch, 22 to 25. We charge 18 to 20 for our FP3 cases, so we try and stick about 5,000 more per arch. If we're doing 4-on-8, so we're just doing more bridges, more implants, then I think we're into the 30 per arch territory. We have providers in Chicago, San Diego, Florida that I think charge a decent amount more than that.
Yeah. No, I mean, for your time, I think that makes a lot of sense. So I'm kind of, I didn't mean to cut you off there.
No, you're good. It's just, but at the same, I don't know, at this point I have a hard time with how much we do. If they're a candidate for FP1, I have a really hard time telling them that for $5,000 less, I'll remove the bone and do an FP3. So I think
because they'll just take that. They don't value it the same way.
Yeah. And so it's, for me, I try and do what I can to get, if they're a really good candidate, they've got loads of bone, they're young, then I'll do what I can to push them into that FP1. And for me, it doesn't cost much more as far as lab fees and everything. It doesn't cost me a ton more to do an FP1 versus an FP3. It's only my time. And it's just that initial surgery day. Everything thereafter is fairly similar to an FP3 case. So, for me, if I've got a young patient, I can discount it a little bit to get them in and help them preserve a little bit of bone, then I'll do that.
So I'm curious about, at the flagship office that you're working at, what's the whole infrastructure that you have? So you have a ton of ops, how many providers, is there an in-house anesthetist, things like that? What kind of volume are you guys looking at per month? Only share what you're comfortable with, of course.
No, yeah, we built this office, I believe about 3 years ago. We're pretty close to kind of right in the heart of Salt Lake County, so a pretty good location. We've got 18 operatories in this office. We've got 2 surgical suites. We actually regret only making 2 of those.
That's quite a ratio.
Yeah, at the beginning, we didn't know how much this was going to take off.
Yeah.
And so Randy, my partner, he kind of switched a while ago to only doing full arch. I mostly do full arch right now. I still love prepping veneers, and I love doing root canals, and I'll do all sorts of stuff. I like it all. So we have an associate that does most of the general dentistry here. We trained a doctor about 2 years ago that ended up staying on with us, Dr. Weisenberg, and he helps me with the training. he's super knowledgeable and he's been great to have around. So we've got basically the three of us, Dr. Roberts, myself, and Dr. Weisenberg, that are mostly full arch. As far as, we try and get about 2 cases a week for each of us. Doesn't always happen, but yeah, we're doing quite a bit here. And like I said, most of it, about half of it, is patients that travel in from across the country.
Yeah. Yeah. I'm curious about how you guys kind of got the word out. And then, because from what little I do know about 3-on-6, I do see people asking about 3-on-6 and all the other dental implant groups that I'm a part of, and a lot of those, most people are talking about FP3.
Yeah.
I'm talking about prices between, I went to Clear Choice, I went to Nuvia, I went to so-and-so. But every now and then someone will say, oh, what about 3-on-6, yada, yada, yada. Right. So I'm curious, where'd that national appeal come from, and how does that usually work when people are traveling in and then traveling back, and how do you kind of work that out logistically?
Yeah, it's kind of funny. It's grown so much in the last few years. I was renewing my malpractice insurance here in Utah, and I was going through the questionnaire, and at the very end it said, do you do all-in-4 or 3-on-6? And it was funny to see that specific on a malpractice. It's just in the last 2 years kind of done this. We put out a lot of content on YouTube initially. We still do a decent amount. And so most of our patients, basically I would say 90% of them come to us after they've been told by someone they need an all-on-X. They go on Google and they type in all-on-X versus, and 3-on-6 is the only other thing to come up. And that's going back to what we said about having a marketable FP1, basically.
Yeah.
And so a lot of it is just the content that we put out, and then these Facebook groups started. And so patients talk within those groups about what we're doing. And so if someone is searching for an alternative to all-on-X, they usually find us because of the stuff that we've been putting out there. The idea of starting this licensing program was, well, don't travel to us. Stay where you're at. This is a lot less complicated if you're close to your house.
Sure.
And so that was the main goal. And I think we've done a pretty good job with that. And these doctors that are doing a lot of this are getting a lot of notoriety in those Facebook groups. People saying, I went to Dr. whatever, and he's doing awesome cases, and they're showing their results. And so we get less and less of these patients traveling in from out of state, which is good. But yeah, I would say online, YouTube videos, that kind of thing. And yeah, it's funny. We're starting to see YouTube content against us. Guys that think that what we're doing is crazy, which is perfectly fine. But it's been around forever. This isn't something really new. It's just a way to do it affordably and predictably, in my mind.
Well, I think that everything the three of us do was crazy at one point. So
yeah, exactly.
All right, guys. So thank you so much for listening to part 1 of our episode with Dr. Logan Locke discussing 3-on-6. So we talked a lot about the context of 3-on-6, where it's coming from, and the general concepts. But for part 2 next week, we're going to be going into all the odds and ends, the nuts and bolts, learning how to really accomplish this procedure, and how you too can also be a provider of 3-on-6. So stay tuned, and thanks for listening.